Bismillahirrahmanirrahim. Assalamu alaikum everyone. I'm Dr. Ambreen and I'm going to deliver you a lecture on basic principles of the chemotherapy, and we will also discuss about the sulfonamide and trimethoprim. Chemotherapy is one of the very important chapters that we are going to study in the subject of pharmacology and therapeutic too. What is chemotherapy? Chemotherapy, as the name is indicating, something about chemicals and therapy. So the use of the drugs or any chemical agents or substances derived from certain microorganisms which have a selective toxicity against infections, viruses, bacteria, and protozoas or fungus are said to be chemotherapeutic agents or chemotherapy. Antibiotics are the medicines that help to stop the infections caused by the bacteria. So in this chapter, we will mainly discuss certain types of the antibiotics. So what is antibiotic? Anti is to stop what? To the bacteria or certain biological organisms. So they are the medicines that help to stop the infections caused by the bacteria. So they do this by killing the bacteria, so keeping them inhibited from copying themselves or reproducing. So they do by killing them or keeping them away from multiplication and reproducing. So the word antibiotics mean against, the bio mean life. So a drug that kills germs in your body is technically an antibiotic. A drug that kills the germs in your body is technically an antibiotic. There is a long history of like these chemotherapeutic agents, like from till 1900 centuries to 19 to 1930. There are a number of scientists that has worked on this, like antibiotic agents, and they developed a history of this chemotherapeutic development agent. So I will discuss them individually in like certain classes of antibiotics. The point is, what are the basic principle of antimicrobial therapy? I mean, what are the points or what are the indications that after which you must think about that you must need to like take antimicrobial agents? Basic principle is for like utilization of this antimicrobial therapy is first of all diagnosis. The diagnosis of with like any condition are very important. Mean you must know about the site of infection, and especially you must know the responsible organism that has. There are a number of the gram positive, gram negative like organisms that are present. You must know about the responsible organism, and then the point is when you're going to take some drug, you must know either this drug is sensitive for that organism for which this is like you are going to use. And randomly what happens is in a daily life we usually take any antibiotics whenever we have a any pain in stomach or anything like infection, or we feel a throat or a cough. What we use is we start augmented without even thinking about what can the possible organism that is responsible, either this drug augmented is responsible for that drug or not. So this is important. You must think always about the site of the infection, the responsible organism, and then the drug that you are going to use in that infection. Then always decide that chemotherapy is necessary in the case you are going to use. So there are two cases: infection, acute infection, the chronic infection. In acute infection, usually the chemotherapy serves like useful because and the point it is the point when the infection is actually reproducing and multiplying. While in chronic infection is not required because in case of chronic infection the bacteria has completely multiplied and it has reproduced so many copies that it has invaded all the almost sites in your body, and so the chronic abscess found respond poorly in case of an antimicrobial therapy. Although the chemotherapy cover is essential if the surgery is undertaken to avoid a flare-up of infection, but it serves less like a response. The next is select the drug. Always select the drug that has a spectrum of activity according to the need. Antimicrobial activity against the drug. Pharmacokinetic profile is also important. The physicochemical properties of the drug. Then the patient-related factors. Either the patient is allergic or not. Either the patient is female is pregnant or not. Either she or he have any renal disease. These are the point of the constitution that you must think when you are going to select any drug. Spectrum of activity, antimicrobial activity of that drug against that like organism, the pharmacokinetic profile, the patient related factors are also like going to serve very important like in such a case. The next other few principles is the frequency and duration of the drug administration. Mean for how much duration, mean how frequently you must take this drug, or how for how much long time you must take this drug. This is also important. You usually have heard that the antibiotic should take for 5 to 3 days, 7 days. So what happens is, in a normal routine, when we are going to take an antibiotic against certain conditions, what happens is, when I started the antibiotic and after 2 to 3 days, if I feel better, I usually stop the like antibiotic. But this is not like good, because your inadequate dose has actually developed the resistance. So in a case you have started the antibiotic and you stopped it after 2 to 3 days or 3 to 4 days, you felt that I'm feeling better. But what happens after like few days, what the bacteria or that like infection, the organism but continues to like, at that time it has suppressed, but after you are going to stop the drug, it again multiply and reproduce so many copies that it again flare up and give you an like exaggerated like sort of response. So again you start your antibiotic, but in such a case, when you again start your antibiotics after again like attack of that bacteria, the antibiotics have no useful like effect, because it does not it does not respond towards like that antibiotic. What happens is the bacteria actually has developed resistance. The bacteria is now very like you can say clever. It has multiplied. It has made it stronger, and as it has like become tolerant to that drug. So when you again take that drug, usually what happens, the bacteria shows resistance towards drug. It says that I don't bother you, and it shows resistance. So always intermediate doses may not cure the infection. Optimized dose should always be used when you are using antibiotics. Please, and optimized dose should always be preferred for the patient when they are going to use antimicrobial agents. Thus, you must continue the therapy in acute infection treated for 5 to 10 days. But some of the bacterial infection exceptions are like typhoid fever, tuberculosis, infective endocarditis. After the clinical cure, the therapist continues to avoid the relapse. In tuberculosis, you have heard about the treatment of tuberculosis that is prolonged, like 6 to 9 months are required. Even after 1 to 3, 4, 5 months, if you are feeling better and you feel no clinical symptoms like related to the one you previously had, still you must continue these drugs, because the bacteria, the organism that is responsible for the tuberculosis is so actively like resistant that it show resistance become dormant. So if you stop the treatment before like using before like its complete like elimination or its duration of course, so what happens is the bacteria against like give you remission or re-attack of its like effects. The next is test for the cure. After therapy, symptoms and signs may disappear even before even the pathogen is eradicated. Like I said earlier, you were taking the medicine for 2 to 3 days and you are feeling better. I mean, the symptoms and signs may disappear before the pathogen has been eradicated. So you always need to complete the course of treatment or course of like those antibiotics. Prophylactic chemotherapy. Sometimes you prophylactically or you use these chemotherapeutic agents to avoid the flare up. For example, during surgery, the patient is very prone to have an infection or especially hospital acquired infection. So the patient is prophylactically like planned to give the chemotherapeutic agents to avoid the infections in hospitals. The next is classification of antimicrobial agents. Mean you are going to classify these antimicrobials in different categories on the basis of the different like points, like on the basis of chemical structures, on the basis of mechanism of action, sometimes on the basis of the type of organisms against which primarily they are active, on the basis of spectrum of activity and type of action, either the bacteriostatic or bactericidal, on the basis of the source of antibiotics. These are the types of the classification on which you can classify these antibiotics. We will discuss them a few of them among this type of classification, like the one that is based on the mechanism of action. Antimicrobials are classified as those antibiotics that like inhibit the cell wall synthesis. There are certain antibiotics that damage the cell wall, so they affect the bacteria. There are certain antibiotics that bind to the ribosomes and inhibit the protein synthesis, as the ribosomes are responsible for the protein synthesis. So when they're going to bind to the ribosome, they are going to inhibit the protein synthesis that has been caused by the ribosome. There's certain class of the drugs that inhibit the DNA gyrase activity, so they inhibit the replication and the transcription and translation of the DNA. Some drugs inhibit the DNA functions by decreasing the DNA-dependent RNA polymerase activity. In some of the drugs, interfere with the metabolic effects, like sulfonamides are very like effective and interfering with the metabolic synthesis of the bacteria folic acid. So we can classify the antimicrobial agents on the basis of their mechanism of action like this. You can see in the picture, this is a picture of the microorganism, and there are certain drugs that inhibit the cell wall synthesis. There are certain drugs that interfere with the metabolism, like sulfonamide. There are certain drugs that affect the cell membrane, and there are a few drugs that affect the DNA kinase activity that inhibits the protein synthesis by inhibiting the ribosomes. You can see some of them affect the messenger RNA coding, and thus affect the like bacteria. So these are the names of the drugs that are being used, like sulfonamide inhibits the metabolism of synthesis of dihydrofolic acid. We will discuss each class. Like penicillin are going to inhibit the cell wall synthesis, aminoglycoside are going to miss the reading of the messenger RNA coding, and fluoroquinolone inhibits the DNA guys. We will all discuss all these like drugs, all these categories in detail in our coming lectures. Penicillin, cephalosporins, vancomycin, bactericin, cyclosporine, they inhibit the cell wall synthesis. Polymyxin, ferrotyrosine B, is starting to damage the cell membrane. Chlorphenicol, tetracyclines, erythromycin, aminoglycoside, clindamycin, they all bind to the ribosomes and inhibit the protein synthesis. So we'll discuss them in detail in our coming lecture, don't worry. The next is fluoroquinones like ciprofloxacin, norfloxacin, sparfloxacin, levofloxacin. They all inhibit the DNA gyrase enzyme. Rifampicin being used in the tuberculosis, they inhibit the DNA function, so decreases the DNA-dependent RNA polymerase activity. Sulfonamides, trimethoprim, primethamine, they all interfere with the metabolic steps of the microorganism. So this is a classification based on the type of the organisms, like antibacterial, those drugs, antiviral, antifungal, antiprotozoal, antihelminthic. This is the classification on the basis of spectrum of activity, narrow spectrum, then is broad spectrum. Narrow spectrum means it is effective against specific type of organisms like either gram-positive or gram-negative. The next is broad spectrum, either against, they are actually effective against wide spectrum range of bacteria like both gram-positive and gram-negative. Tetracycline, chlorphenicol are broad spectrum. Narrow spectrum is penicillin, streptomycin, erythromycin you have commonly heard. It's a narrow spectrum antibiotic. The next is type of action. There is two type of action that a drug can perform: bacteriostatic or bactericidal. Bacteriostatic means the drugs that inhibits the growth of the bacteria, that inhibit just the growth, copying, replication, reproduction of the bacteria. The next is cidal, kill, CIDL, cidal, that kill the microbes that are going to finally degrade or kill those microbes. The bacteriostatic means static, suppress, inhibit the growth of bacteria. Cidal, that kills the microbes. Fine. This is a picture, just a graphical representation of bacteriostatic or cidal. Like this one is the red one curve is going to kill the microbes, and they are going to actually decline. And this graph is just to show if there is no drug and the bacteria continues to multiply, reproduce, and continues to do action. The blue one is bacteriostatic. The point is, what is the main significance of using bactericidal or bacteriostatic drugs? Normally, as the name is indicating, bactericidal are those that kills the bacteria. Static are those that suppress the bacteria. The point is, if you have an option to kill the bacteria, why you are going to use these bacteriostatic drugs? I'm going to tell you one important thing. Bacteriostatic drugs are very good. They are considered more like effective as compared to cidal. This is somehow a thing to like ponder that why the bacteriostatic are preferably more good when you have a cidal, and cidal is the one that is going to kill the bacteria completely. Static are those that suppress the bacteria. Cidal are those that kill the bacteria. And I am saying static are more good, while you can see the cidal are more good. Static are just because of the reason more good that the static are going to suppress the growth. They are going to give an option to your immune system to deal with that bacteria. They are going to control the bacteria and giving a chance to your immune system that is very good if it works its own way. But due to the increased number of the bacteria, our immune system was not able to deal it. So when we have decreased its like growth, its action, its multiplication, now we are giving a chance to our immune system to deal it. So when our immune system kill it, it's more effective instead we give a drug that kills the bacteria. But sometimes we need to to kill the bacteria, so we prefer to use the bactericidal. But when we have an option of static incidal, we preferably use static. Fine. This is an important thing. Inshallah, I'll discuss this again in our coming lectures. Then next is source of antibiotics. Penicillin, cryophyllins, cephalosporins, polymyxins, tyrotheracin. They are bacteria obtained from bacteria. They are obtained from fungus. Some are obtained from actinomycetes. Next are the problems that are commonly being faced with antimicrobial agents. The common problem with this is one of the very common problem is drug resistance. The bacteria shows resistance towards the drug. The next is hypersensitivity reaction. Toxicity is very common with these antimicrobial agents. So always when you are going to say antibiotics, always consider the side effects. They are also very important. Drug tolerance also develops super infections, like one of the other problem that we face with the antimicrobial agents. So what is resistance? Resistance is unresponsiveness of microorganism towards antimicrobial agents. These bacteria show unresponsiveness, means resistance, they become tolerant for the drug. So the resistance can be natural by nature or can be acquired with the passage of time. It has modified itself and like developed the resistance. Natural resistance is the organism never respond to that agent, maybe due to absence of the enzymes or target sites affected by the drug. Like gram bacilli are not sensitive to penicillin G, but this type of resistance is clinically not problem as we have alternative drugs available to deal with this penicillin G. The next is the microbes which were previously sensitive to antimicrobial agents now become resistant to it. This is a clinically and that poses a problem that causes a problem for us. Then the bacteria initially responsive, but now resistance. The reason for this is bacteria acquire the resistance by the change in their DNA, such as the DNA changes may occur by mutation, transfer of genetic material. And the mutation is what is mutation? Genetically change that occurs spontaneously. In any population of the bacteria, there are few resistant strains that are present. So when a sensitive organism is destroyed by antibiotic, the resistant mutants freely multiply. They are resistant mutants. They are the ones that are very naughty, and they continues to multiply, and they are not being like going to respond those antimicrobial agents. Many bacteria contain genetic materials called plasmid in their cytoplasm, which carry the genetic coding for the resistance. These plasmids are transferred to other bacteria, and they spread the resistance. There are different modes of the transfer of genetic materials. You have already studied in the biology, like transduction, transformation, and conjugation. So to this, the bacteria is going to become more resistant. As a result of this resistance, they produce more enzymes that inactivates the drug. Now the bacteria is so resistant that it produces like enzymes to inactivate the drug we are going to take. Like beta lactamases are being produced by Staphylococcus. Aminoglycoside inactivating enzymes are being produced by Escherichia coli. Sometimes there is a decreased accumulation of the drug in the bacteria. This is a bacteria, the drug is going to go inside the bacteria, but the drug has decreased the accumulation of, it does not allow this drug to come and accumulate it and destroy it. So resistance to tetracyclines by gram-positive and gram-negative bacteria is also very common. Some bacteria, like what they do is they alter the target of the drug. Drug has to bind to receptor and then it has to enter into the organism. The bacteria has actually alter the target site. It does not like you can say it does not invite and like respond towards the drug, and actually it like alters its binding site and change the shape of the site, and the drug is not able to like you can say identify the site, and this way the drug is not being responded by this bacteria. Sometimes the bacteria alter the metabolic pathways. They produce folic acid like by another pathways, like in case of sulfonamide tolerance. Now, this is a term named as cross resistance. Resistance seen among chemically related drugs. When a microorganism develops resistance to one drug, it is also resistant to other related drugs. Superinfection and new infection occurs in a patient having pre-existing infection. The patient is going to take some antibiotics in case of some pre-existing infection, but by the use of these antibiotics, the patient is going to prone to have another infection named as superinfection that is most difficult to treat. The next is how we are going to choose an antimicrobial agent. This is also important. You must always think about the patient-related factors. Either the patient is eligible for that drug, either a patient, if she is female, either the patient is pregnant, or if she is lactating mother. and either she can take. There are certain drug factors or organism-related consideration that we must take. In case of the patient-related factors, patient age is very important. Chlorphenicol produces gray baby syndrome in the newborn, so newborn should be contraindicated to take the chlorphenicol. Tetracycline's deposition in teeth and bone may below the age of 6 years is also like contraindicated because it causes the deposition in the teeth and bone. Renal and hepatic functions, like in case of this, monoglycoside, vancomycin, renal failure, erythromycin, and tetracycline in case of liver failure, they must not be used. So you always like consider the side effects as you're going to indicate some drugs. All the antimicrobial agents should be avoided in the pregnant women. Many cephalosporins and erythromycin are safe, while safety data on most other is not available. Genetic factors also affects like the primaquine sulfonamide fluoroquinol is likely to produce hemolysis in the glucose 6-phosphate deficient patients. Then organism-related consideration. A clinical diagnosis should always be made. You must know about the specific organism as you're going to choose an antimicrobial agent. This is very important. So then choose choice to be based on the bacteriological examination, like bacteriological sensitivity testing. Then drug factor. A drug factor includes a spectrum of activity, either the narrow or broad, either which you require type of the activity, sensitivity of the organism, relative toxicity, pharmacokinetic profile, route of administration. The cost of drug also affects the utilization. And sometimes we use the combination or combo antimicrobial agents. What is it? To achieve the synergism, like in case of TB, rifampicin, isoniazid are combined to reduce the severity or incidence of adverse effects, and ferroterracin B and rifampicin are being used to enhance the antifungal activity of ferroterracin B. There is sometimes to prevent the resistance in case of the drugs being used in the TB. We use to prevent the resistance against the drugs. So we use combined therapy of combined use of antimicrobial agents. Sometimes to broaden the spectrum of antimicrobial agents, we use these drugs in combination. Prophylactic use of antimicrobials. Prophylaxis against specific organisms like in cholera, tetracycline prophylaxis, malaria for travelers to endemic areas may take chloroquine or mefloquine. Prevention of infection in high risk situations, as nowadays prophylactically we must like prevent the exposure of like corona patients, so we must take care of them ourselves. And preventive measures are we should take care of safety and all things. Prophylaxis of surgical site infection. Prophylaxis against specific organisms. Prevention of the infections in high risk situation, as nowadays. Prophylaxis of surgical site infection. Last thing, why we are going to discuss the basic like the principles of antimicrobial therapy is failure of antimicrobial therapy. The failure is somehow due to improper selection of antimicrobial agents, the dose, the route, and duration of the treatment. Treatment begins too late. The bacteria are invaded all over your body. Failure to take the necessary adjunct measures, poor host defense mechanism, trying to treat the untreatable infections, presence of dormant or altered organisms which later give rise to the relapse. The next are sulfonamides and trimethoprim. We just take a break and just give a glance on the previous point. So we discuss about the basic principles of the chemotherapy, and we have classified the drugs on the basis of the mode of action, on the basis of the sources, on the basis of the spectrum of activity, and the basis of the type of actions. Right? So it said our term bacteriostatic, bacteriostatic mean drugs are those drugs that suppress the growth of the bacteria. Bactericidal are those drugs that kills the bacteria. Then we have gone through a term broad spectrum antibiotic and narrow spectrum antibiotic. Broad spectrum are those which are effective against both against gram-negative and gram-positive bacteria. The other one is against effective against both gram, like only is specific for either gram-negative or either gram-positive bacteria. This is narrow spectrum. Now we are going to start sulfonamide, trimethoprim, and cortimoxazole. Sulfonamide are derived from two words, sulfona and amide. They are derivatives of para-aminobenzene, commonly referred as sulfur drugs. In 1932, Gerhard Demark discovered these sulfonamides. He had classified the sulfonamides on the basis of duration of action into different categories like short-acting, that have a duration of action of 4 to 8 hours, like sulfadiazine and sulfoxazole. Intermediate acting is that have a duration of action like 8 to 12 hours. Sulfamethoxazole. Long acting is sulfadioxine and sulfamethoxazine. Special purpose sulfonamides are sulfacetamide, mefenamic, sulfasulfadiazine. Fully absorbed sulfonamide is sulfasalazine. Antibacterial spectrum of these sulfonamides, they are bacteriostatic. We just said that bacteriostatic are those that are going to suppress the growth of bacteria. So they are effective against gram positive and gram negative, mean they have a broad spectrum of activity. So in a high concentration, they also act as bactericidal. Normally they act as bacteriostatic, but in very high concentration, they may serve as bactericidal. Primarily used to prevent the urinary tract infection. That it was previously being used to deal with the urinary tract infection. Mechanism of action. These bacteria that for which we are going to use sulfonamide, they synthesize their own folic acid from para-aminobenzoic acid and is taken up from the medium. Sulfonamides is structurally analog of para-aminobenzoic acid, so they inhibit the bacterial folate synthase enzyme and formation of the folate get inhibited. Sulfonamides completely inhibits the para-aminobenzoic acid and to produce the dihydrofolic acid. You can see in this figure, the para-aminobenzoic acid converts into dihydrofolic acid by the help of dihydropyranate synthetase enzyme, and sulfonamides inhibit here. The next we are going to discuss in the coming few slides is trimethoprim that inhibits the dihydrofolate reductase and by inhibit the conversion of dihydrofolic acid to tetrahydrofolic acid. Sulfonamide, there is a question that sulfonamides either can affect the human folic acid. The answer is no, because human also require folic acid, but they utilize free-from folic acid synthesized in the diet and are affected by sulfonamides. So only those microbes which synthesize their own folic acid can't take it from the medium as susceptible to sulfonamide. But the sulfonamide faces resistance from most of the bacteria because most of the bacteria are capable of developing this resistance by how they develop by mutation or by transfer of the resistance by plasmid. So when an organism is resistant to one sulfonamide, it shows resistance to all sulfonamide. This is called cross resistance. The resistant mutants are actually going to produce the increased amount of para-aminobenzoic acid that is not going to be controlled by for this sulfonamide. Microfolate synthetase enzyme has low affinity for sulfonamide. They adopt an alternative pathway in folate metabolism. Pharmacokinetic profile. They are usually not given topically because of the high risk of allergic reaction. They are readily absorbed in the GIT and reaches the maximum concentration in the plasma 4 to 6 hours. They cross the placenta and blood-brain barriers and are available in free at inflammatory site. It is metabolized in the liver by the acetylation, excreted by kidney through glomerulus filtration. Its metabolites are insoluble in the urine, hence crystalluria is very common. The diverse effect of sulfonamide is so much, so we must think about them. They are nausea, vomiting, diarrhea, abdominal pain. Hypersensitivity reactions are very common. Really, Stevens-Jones syndrome is present. They produce conjecture. Conjecture is bilirubin-induced brain dysfunction in neonates because of the displacement of the bilirubin from the serum albumin binding site. Albuminuria means albumin proteins in the urine, renal irritation, severe adverse effects, crystalluria, and the patient has glucose 6-phosphate deficiency. Sulfonamides causes hemolytic anemia. Contraindication, they should not be given during pregnancy and in infants. There is some interaction of the sulfonamides. They inhibit the metabolism of phenytoin. Phenytoin is the anti-epileptic and anti-arrhythmic. Tolbutamide is the oral hypoglycemic drugs. Warfarin is anticoagulant. Trimethoprim. This sulfonamide is bacteriostatic. Trimethoprim is also bacteriostatic. Sulfonamide inhibits the dihydrosynthetase enzyme. They inhibit the dihydroreductase enzyme. They are also preferably being used for UTIs. They are also preferably being used for UTIs and respiratory tract infection. The spectrum of activity is bacteriostatic. Similar to that, they are effective against many gram-negative and gram-positive bacteria. Sulfonamides, triphthophorims are being used in combination, and their combination is bactericidal in spite of the fact they individually are bacteriostatic in nature, but their combination is bactericidal against many organisms. So we preferably use them in combination. Adverse effect is nausea, vomiting, skin rashes, and patients with the folate deficiency, trimethoprim results in megaloblastic anemia. Now we are going to discuss the combination of the sulfonamide and Trimethoprim. The fixed dose of the combination of trimethoprim and sulfamethoxazole is called cotrimoxazole in ratio 1 to 5. It was introduced in 1969 to block the folate metabolism, like in a sequential effects, and we want to get bactericidal effects. So both the compounds are bacteriostatic, but the combination becomes cidal against any organisms, pathogens. Maximum synergism is seen when the organism is sensitive to both compounds. Uses: it is being used in treatment of urinary tract infection, respiratory tract infection, pneumonia by pneumocystis jirovecii. It's a drug of choice in such a case, typhoid, bacterial diarrheas, and dysenteries. And in chancreite, it's a bacterially sexually transmitted infection. A drug of choice is these, like you can say, cotrimoxazole. All the adverse effects seen with the sulfonamides can be produced by cotrimoxazole. So in the patients with the folate deficiency, it results in megaloblastic anemia along with nausea, vomiting, glossitis, and stomatitis. This should not be given during pregnancy. Fine, elderly people are having greater risk of development of bone marrow toxicity. So this was all about the basic principles of the chemotherapy, then about sulfonamide, trimethoprim, and about the cotrimoxazole. Thank you so much for this lecture. Inshallah, see you in the next chapter related to chemotherapeutic agents. Allah Hafiz.